Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome, everyone. In this episode, we are talking all about polycystic ovarian syndrome, or PCOS, a multi-system reproductive and metabolic disorder affecting people with ovaries who are of reproductive age, so about 18 to 44 years old. It has been estimated that PCOS affects somewhere between 4 and 12% of reproductive age individuals with ovaries. But it is thought that there are many undiagnosed cases, as much as 60 to 70%. There also appears to be familial clustering of PCOS, so those with a first-degree relative with PCOS have a higher risk of PCOS themselves. I want to start by discussing the name. The name polycystic ovarian syndrome is meant to describe the appearance of the ovaries, which has many small fluid-filled sacs. But these are not cysts. These are follicles, small fluid-filled sacs that hold immature eggs in people of reproductive age with ovaries. In those with PCOS, there are usually a large number of follicles on the surface of the ovaries, and they often resemble a string of pearls. So that is where the name polycystic ovarian syndrome comes from, even though these are not true cysts in the ovaries. Now, what exactly is PCOS? The physiology and cause of PCOS is complex and not well understood. Thinking of it simply, the hormones between the brain and the ovaries are not communicating properly. The result is elevated luteinizing hormone, or LH levels, coming from the pituitary gland in the brain, which leads to increased androgen production from the ovaries, so hormones like testosterone. These elevated androgens lead to multifollicular development. This causes the polycystic appearance of the ovaries on ultrasound. These elevated androgens also lead to elevated estrogen levels in the blood, which feed back to the brain and decrease follicle-stimulating hormone, or FSH levels, and cause irregular or no ovulation. Insulin resistance is also seen with PCOS, in some but not all cases. With insulin resistance, cells are not taking up glucose as they normally do. The high level of insulin in the blood leads the ovaries to produce more androgens, which once again prevents or inhibits ovulation. These elevated androgens and elevated insulin levels may also lead to abdominal fat deposits and weight gain that is commonly seen with PCOS. Symptoms of PCOS are quite varied, from individual to individual, but also in the same individual over time. Some of the more commonly reported symptoms include irregular periods, acne, oily skin, excessive hair on the face or body, also called hirsutism, dark or thick skin patches in skin folds like the neck and in the armpits, also called acanthosis nigricans, androgenic hair loss or hair thinning, meaning along the hairline, weight gain, especially centrally around the abdomen, and infertility. PCOS is also associated with a number of medical conditions, meaning the risk of these health issues at some point in your lifetime is increased if you have a diagnosis of PCOS. This includes type 2 diabetes, high blood pressure, high cholesterol, heart disease, and precancer and cancer of the uterine lining. I want to take a moment to discuss and understand this risk of precancer and cancer of the uterine lining, or endometrium, and why it is increased in individuals with PCOS. If an individual does not have regular menstrual cycles due to irregular ovulation or no ovulation, then there is estrogen from the ovarian follicles acting on the lining of the uterus to thicken it, but no progesterone, which usually comes from the follicle which matures and ovulates an egg. It is this unopposed estrogen over long periods of time that puts people at risk of developing precancerous and cancerous cells of the uterine lining. This is why I tell my patients with irregular cycles that if they are not trying to conceive and seeking fertility treatment, and their period space more than 3 to 4 months apart, they should see their primary care provider for either the birth control pill, patch, or ring, which can be taken daily, or progesterone, which can be taken for a short time every month or every few months. All of these medications help to shed the lining of the uterus, which is protective against the unopposed estrogen. Now that we have reviewed the basics of what PCOS is, the main symptoms, and the long-term health issues that may develop, let's talk about diagnosing PCOS. PCOS is diagnosed using the Rotterdam criteria. According to these criteria, diagnosis of PCOS can be made if 2 out of 3 criteria are present. 1. Polycystic ovaries on ultrasound. This means 12 or more follicles in at least one ovary, or a volume of 10 milliliters or more in at least one ovary. 2. Irregular or no ovulation. And 3. Evidence of high androgens, either in blood work or clinically, such as the presence of acne or increased hair growth, or androgenic hair loss or thinning. Newer guidelines have suggested updating the follicle count to 20 or more follicles in at least one ovary to meet the criteria for polycystic ovaries on ultrasound. Diagnosis is made with a thorough history, a physical exam, blood tests, and an ultrasound. Part of doing blood work is to assess androgen levels for the diagnosis of PCOS, but also to rule out other causes of irregular or no menstrual cycles, such as thyroid issues, high prolactin, premature ovarian insufficiency, congenital adrenal hyperplasia, and pregnancy. Treatment for PCOS can be divided into options for those trying to conceive versus for those who are not trying to conceive. For those trying to conceive, treatment may start with lifestyle changes, including optimizing diet and exercise, because this is important for a healthy pregnancy, but also because even a 5 to 10% loss in weight in individuals with an elevated BMI has been shown to help spontaneous ovulation and spontaneous pregnancy rates. Since PCOS is also associated with insulin resistance, prediabetes, and diabetes, weight loss can also help control sugars and decrease the risk of progressing to diabetes in those who do not have it. Treatment of increased hair growth when trying to conceive is limited to mechanical hair removal, so options like shaving, waxing, laser hair removal, and electrolysis. Treatment for irregular cycles while trying to conceive is focused on ovulation induction, so helping to mature and release an egg. Oral medications, or sometimes injectable medications, are used to help develop a follicle and induce ovulation. And this can then be combined with either timed intercourse or intrauterine insemination, or IUI. For those individuals who are not trying to conceive, lifestyle modifications with diet and exercise are still very important to try and achieve and maintain a healthy BMI, normal blood pressure, good cholesterol levels, normal sugar levels, and overall good metabolic health and uterine health. Treatment of increased hair growth has more options for those who are not actively trying to conceive. In addition to mechanical hair removal, there are anti-androgen medications that may be used, such as the birth control pill, spironolactone, cyproterone acetate, flutamide, finasteride, and Vanica. Treatment for irregular cycles in those who are not trying to conceive is focused on protecting the uterine lining from developing precancerous and cancerous cells, rather than a focus on ovulation. As discussed earlier, if individuals are having a menstrual cycle less than every 3 to 4 months, it's imperative to consider a medication to protect the uterine lining. The birth control pill, patch, or ring can be taken daily, or progesterone can be taken for a short time monthly or every few months to shed the lining of the uterus and protect that lining. A few take-home points I want to now highlight from this discussion of PCOS, irregular menstrual cycles, and fertility. 1. You do not need to try to conceive for 1 year or even 6 months before seeing your healthcare provider for investigations for irregular cycles. It's important to have a workup to look for the causes of irregular cycles and see if there is any treatable issue playing a role. If there is no treatable or reversible issue, you may need some medication to help you ovulate and then try and conceive, as is the case with PCOS. 2. Polycystic ovaries does not equal PCOS. Polycystic ovaries is an ultrasound finding. A diagnosis of PCOS requires a thorough history and investigations, including an ultrasound, but not an ultrasound alone. 3. It is important to have a period at least every 3 to 4 months when you are not trying to conceive. This ensures that the uterine lining is being shed and you don't have unopposed estrogen acting on the uterine lining and increasing the risk of cancerous or precancerous cells of the uterus. Now let's take some time to go through some questions I hear about PCOS so you can better understand this diagnosis. First, can PCOS be cured? PCOS is a chronic condition. It cannot be cured no matter what you have heard or read, or any supplements or treatments that may promise this. That said, symptoms may be treated and improved through lifestyle changes, medications, and other specific treatments like fertility medications for irregular ovulation. For example, weight loss is a lifestyle modification as well as a treatment. A 5 to 10% loss in weight in individuals with an elevated BMI can help with ovulation and spontaneous pregnancy rates. And it may also help with response to medication in those doing fertility treatment, as well as blood pressure, sugar, and cholesterol control. Another common question I hear is, I read about metformin for fertility in people with PCOS. Do I need this? Metformin is an oral medication used to treat diabetes. It is used as a treatment in people with PCOS for various reasons. First, it is used to treat diabetes or prediabetes diagnosed in individuals with PCOS. But it has also been used alongside ovulation induction medications like clomiphene citrate and letrozole to help with ovulation. Specifically, metformin has been shown to be helpful in patients who are resistant to ovulation induction medications or patients with elevated BMI or specifically increased abdominal weight. The last question I want to address is, I have PCOS and was told I will not be able to get pregnant. Is this true? This is not true. People with PCOS can conceive. One of the key issues tends to be irregular ovulation. Without an egg maturing and ovulating predictably, it is harder to conceive. That said, a combination of lifestyle changes and ovulation induction medications can help overcome these difficulties and improve chances of pregnancy. Also, sometimes people with PCOS do spontaneously ovulate and conceive. It's a matter of whether there is sperm present when that ovulation occurs. So there you have it, all about polycystic ovarian syndrome, or PCOS. What it is, how it's diagnosed, and short and long-term consequences of PCOS. It is important to understand the relationship between PCOS and your general health, as well as your fertility, so you can start to modify your own risks and seek help if you are trying to conceive and have irregular menstrual cycles. I hope this episode was useful in allowing you to better understand PCOS, so you know how this condition may affect your fertility and how it can be managed and treated. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health. If you enjoyed this episode, please remember to subscribe to the podcast and tune in to our next episode.